Very good evening, everyone. I think this is the final session for today, and it's not. Two more, okay. All right. This session is basically themed end-of-life issues, and I think it'll be quite interesting. We've got three speakers, and I'd like to introduce our first speaker, Dr. Teh Yuau, who's a consultant geriatric psychiatrist who works in Penang General Hospital. He graduated with MBBS from University of Malaya, did his postgraduate training in Hospital USM, Kupang Krian, and his geriatric psychiatry subspecialty at various local centers as well as Westmead Hospital and St. Joseph's Hospital in Sydney. He will be talking about suicide prevention in the older persons. So without much ado, since we've started 5 minutes late, may we welcome Dr. Teh.
Okay, thank you, Mr. Chairman. Thank you, Mr. Chairman, and thank you, the organizer, for inviting me to share on this topic, suicide prevention in older persons. But in fact, I have a little bit comment that putting my topic under the end-of-life issues. Suicide is preventable, so it shouldn't be end-of-life issues. Okay, let's start with my topic, suicide prevention in older persons. It's a very big topic, so I decided to summarize my talk to 10 fast facts and 3 take-home messages. And of course, I will elaborate a little bit more where the clinically relevant. Okay, so fact number 1, the older persons have a higher suicide rate than younger people globally. Okay, although majority of suicide occur before the age of 50 years old, that is mainly due to higher proportion of population at younger age in low and middle income countries. For suicide rates as concerned, the number of suicides per 100,000 people per year, the suicide rates usually increase with age. Fact number 2, the older people are more likely to die from their suicidal attempt. Okay, from this table, we can see that this is a 10 years report, data from England and Wales. The ratio of deliberate self-harm to death by suicide was about 200 for elderly, but when it comes to people aged 60 years and above, this ratio can come down to as low as 8. 8 suicide attempts that were accounted with 1 suicide, the person died from suicide. And we may ask why? Why higher mortality from suicidal behavior in older persons? First, the older people with suicidal behavior tends to be more determined and less impulsive compared to the younger people when they attempted suicide. They tend to use more immediately lethal means to end their life, and they are generally more frail, thus more likely to die from suicides before they were discovered and rescued. And they also more likely to be left alone, yeah. And fact number 3, past history of attempted suicide is a major risk factor for suicide. In Chiu et al., almost 1/3 of older people who die by suicide had a history of a suicidal attempt. And over 30% of these attempts had occurred within 1 week prior to the suicide. So we shall always take serious concern over every suicidal attempt, especially those involved the elderly, regardless of how trivial the self-harm behavior. Okay, fact number 4, majority of suicide in older people die on their first attempt. Nearly 75% of elderly suicides die on their first attempt. Thus, even in the absence of past suicidal attempts, we need to elicit suicidal ideation actively. Fact number 5, depression is the most vital modifiable risk factor for suicide prevention in older people. Yeah, I need to talk a little bit more about depression in elderly. Okay, as we can see from this table, Mood disorder were consistently identified as the most important suicidal risk factors from the psychological autopsy studies. Depression are common in the community, but most of them do not seek specialized mental health service. However, up to 80% of them had consulted a primary care doctor within a month before their suicide. Thus, it's vital for the primary care physician to pick up the depression and suicide warning signs to prevent suicide among the older persons. Often the older people present with atypical complaints at clinical settings. So, when the direct complaints from history are less reliable, we must not forget another important principle in clinical medicine. Common things occur commonly. The prevalence of depression varies in different clinical settings. In general, the more ill the population, the higher the prevalence of depressions. Okay, take a look at this case scenario taken from New England Journal quite some years ago. Okay, this 70-year-old man whose wife died 6 months previously and presented with foot pain from diabetic neuropathy, poor sleep, lack of energy, and increasing frustration about his inability to keep his diabetics under control. So would you think of depression at this point? On further exploration, and only if you ask, then he reported lack of interest, decreased appetite, weight loss about 5 kilo over the past 3 months, and intermittent thoughts that he would be better off dead. Yeah, so by now, maybe you're convinced that she is depressed. Yeah. Okay. How the elderly patient present with depressions? Okay, they tend to be less likely to directly complain of feeling sad when they are depressed. Even from observation on the effect, yeah, the emotional reaction observed may not be so sensitive and reliable. In contrast, they are more likely to complain of anxiety, forgetfulness, low energy, sleep disturbance, or present with psychomotor agitation or retardations. The older person with depression also may present with more worry about having certain illness, that is hypochondriacal, or over concern of somatic symptoms with multiple poorly explained pain or discomfort over the body. Some may have associated psychosis, such as delusion or hallucinations, and some may present in apathy and poor motivation, possibly more common in vascular depressions. Okay, we still use the same diagnostic criteria, either ICD-10 or DSM-5, to make diagnosis of depressive episode. But a large proportion of older persons with depression, they actually present with a sub-threshold depression. Means that the presence of depressive symptoms are not meeting the number of criteria symptoms needed to make a formal diagnosis of major depressive episode. But for example, in DSM-5, we need 5 out of 9 depressive symptoms present almost all the time for at least 2 weeks. But they may present with only 3 or 4 symptoms, but chronically also having those symptoms. So are those conditions clinically relevant? Yes, from research found that this sub-threshold depression, if persistent, they also associated with a similar increased morbidity, mortality as the major depressive episode. And can we prevent depressions? Or what are the protective factors for depression in late life? From biopsychosocial model, enhancing good medical care, adaptive coping skills, and established social support network, all these protective factors may need actually to start from younger age before reaching the late life. Okay, fact number 6, alcohol use disorder, increased risk of suicide in older people. From my clinical experience, I have seen quite some patients who have been living with some life issues but without apparent depressive symptoms. But when they are under alcohol intoxication, their mood would just crash and become highly suicidal. If the alcohol used in a dependent manner, that means that the person is going to repeatedly exposed to highly suicidal risk. Alcohol use disorder by itself is an independent risk factor for suicide. It also exacerbates co-occurring of other psychiatric illness such as depression, as well as complicating other psychosocial risk factors. Okay, fact number 7 about dementia. Some, but not all, people with dementia are at higher risk of suicide. The diagnosis of dementia by itself does not overall increase the risk of suicide, but people with dementia at mild stage may face a higher risk, particularly if they are comorbid depression with preserved insight and with hopelessness. Fact number 8, perceived impact of physical illness affects the risk of suicide in older people. Presence of physical illness may increase the risk of suicide, but more importantly is how the patients perceive their illness rather than the illness per se. Furthermore, the basal rates of physical illness are very high in the older population. Therefore, to use the presence of physical illness to predict suicide risk may have limited values. And fact number 9 and 10 I put together about psychosocial factors. Some identified psychosocial risk factors for suicide in older people are not independent but mediated by depression. But social connectedness is an independent protective factor for suicide. So stressful life events and perceived financial difficulties increase suicide risk, but likely to be mediated by depression. Social connectedness, however, is recognized as independent protective factor against suicide. Religiousness in general also protective against suicidal behavior, as it confers stronger reasons for living. Most religious teachings objects against suicide, and it promotes social connectedness through religious activities. However, research also found that negative religious coping or religious struggles in older persons, for example, those with thoughts of illness being signs of being punished or abandoned by God, and this may actually potentially cause a paradoxical effects that increase the risk of suicide. Okay, then I follow by 3 take-home messages. Suicide can be prevented. The suicide prevention strategy could be grossly divided into universal prevention, selective prevention, and indicated prevention. Universal prevention apply to all people. Examples include promotion of healthy aging, reducing stigma. Selective intervention target the high-risk group with early identification and intervention. Indicated intervention focus on people suffering with symptoms or at proximal risk of suicide to provide them comprehensive and continuous care. No single intervention can prevent all suicides, but multi-sectoral collaborative approach work the best. Take-home message 2, treating depression is the most effective intervention in preventing suicide in older people. We know that effective treatments are available for depression, yet there are barriers for depressed patients to receive adequate treatment. From the patients, they display fewer warning signs or less willing to communicate their suicidal ideation. At the patient-doctor context, patients tend to complain somatic symptoms, or some physicians may be preoccupied with patient's physical condition, but overlook the mental health. And for various reasons, unwillingness to seek mental health service. At the physician level, inadequate training may lead to therapeutic nihilism or failure to provide adequate treatment. The management of depression starts with assessment and timely identification, which could be helped by high index of suspicion and the use of screening tools. The comprehensive assessment, of course, comprises of good history, physical and mental examination, and investigations based on biopsychosocial approach. Okay, another simple and useful approach I would like to highlight here is the geriatric 5M approach introduced by Canadian geriatricians. The first M focus on the mind. Always consider the mental health condition. At least to consider depression, dementia, or delirium, the 3 common mental health conditions in the older persons. For whatever reason, they come to your clinic settings or in the ward. Encourage mobility and functioning in overall. Examine the medication to see if any medication could have exacerbated depression and confusion. Beware of any concurrent illness that may cause the depression or any implications to be considered sorry, that may complicate the patient's condition and the management. And also assess the risk and prognostic assessment, particularly suicidal ideation, any psychotic symptoms, any cognitive impairment, and functional impairment. Okay, this table summarizes the different diagnosis of depressions and the treatment modality. For subthreshold depression, we can first adopt a wait-and-see approach, but if prolonged and chronic, subthreshold depression may also have the similar implication on morbidity and mortality, thus worth to consider a trial with antidepressant when they become persistent. Okay, one note about electroconvulsive therapy, or in short ECT. It is a very effective treatment to minimize the suicidal ideation over a short period, and ECT remains effective in the older persons. For antidepressants, when we use in the elderly, the usual pharmaco rule of start low, go slow still apply. But we must make an attempt to titrate the dose up to the therapeutic dose for antidepressants to be really effective to treat depressions. Some good practice on educating patients when prescribing antidepressants. Depression is a treatable disorder. Antidepressants are non-addictive. The importance of compliance, the delayed onset of therapeutic effects. Usually it takes several weeks before it really establishes the antidepressant effect. Not to stop treatment when recovery has just occurred, and warn and reassure for usually mild side effects. Okay, take home message 3. Treating depression in collaboration with mental health services improve both outcome of depression and suicidal risk. Okay, from this prospect study, the intervention group, which involved more collaborative care from mental health service, show a better outcome in reducing suicidal ideations. Another study, impact study, in the intervention group, which included a depression care manager, collaborating with psychiatrists and primary care provider, also show a better outcome in both depressive symptoms and suicidal ideation. And last but not least, when to refer for specialized mental health service when the diagnosis is in doubt or complex, including bipolar disorder, when depression is severe, psychotic depression, severe risk to health, that patients have poor oral intake, failure to eat or drink, when there is a significant suicide risk, when complex therapy is indicated, or with complicated medical comorbidities, or as primary care physician, when your first or second line therapy fails, the patient fails to respond. And with that, I summarize this topic in 10 fast facts and 3 take-home messages that related to the prevention of suicide prevention in older persons. With that, thank you.
Thank you, Dr. Tay. Maybe we will leave the questions to the end, all right? I'll try to work out some time. So we'll move on to another speaker. This time we are talking about the total opposite. Instead of preventing suicide, we are moving on to end-of-life issues. And our first speaker who's going to talk on end-of-life issues is Dato Sri, Dr. Thambu Pragasam Devaraj. Of course, he needs no introduction. Everyone, he's much loved and very well known. Dr. Devaraj had studied in University Malaya in Singapore, got his MRCP from the Royal College of Physicians, Edinburgh, and he's also a fellow of the Royal College of Physicians, Edinburgh. He had also done his diploma in palliative medicine from Cardiff University. He started work in Singapore under the Ministry of Health, and then with the Ministry of Health Malaysia, and he's worked in Kuantan, Alor Setar, and Penang. and he was also an honorary consultant physician at Penang Adventist Hospital. And he has also been the Chancellor of International Medical University in the past decade. He was a founder member of the MMA and later elected president, and also an elected member of the Malaysian Medical Council, as well as a member of the MMA Foundation. He is to be conferred the Honorary Doctor of Letters degree, and the award is in recognition of his exceptional contributions and services to the medical profession and community, notably in promoting cancer awareness and importance of palliative care. But he has still not slowed down despite his age. He continues to lead as a vice chairman of the National Cancer Society of Malaysia, Penang branch, and he is a board member of the National Council. So without much ado, call upon Dato' Sri to give his presentation.
I think I must be careful when someone asks me to give a talk at a conference to say as little as possible about myself. All I wanted the chairman to say was that I've been a doctor for some years, and for the last 30 years I've been involved with some hospice work in Penang. Okay, I don't see my first slide, but anyway, what I'm going to talk about is end-of-life care issues and perceptions. Okay. Now, recorded history shows that man was obviously aware of death. And these are some quotations which most of you will recognize from the Bible, from the Quran, and from Tagore. But there is a paradox about life and death today. Life compared to some decades ago, maybe 50 years ago and so on, or you want to go backward some more to 300 years ago, life is easier. Many people are living longer, but most of us not in perfect health. There's increasing medical knowledge and technology, which has led also, or leading to, the push by the patient, the family, and the pull by the medical profession, which may lead to over-medicalization. And dying is becoming harder for patients, family, and health carers. As we all know, we can't deny, but we cannot postpone or avoid death. When the thought of the final milestone comes, some of the fears and beliefs are more about the manner of dying rather than dying itself. I think by that time, most people who have been ill for some time realize that they are dying. It's more the manner of dying than the dying itself. Will there be a lot of suffering? Will it be protracted? Will I be alone? And what happens after death? And this quote from this French philosopher in the 16th century is very true, that neither the sun nor death can be looked at closely. But then, to contrast that is the belief that one is returning to God or will be with the loved ones. And sometimes there are people who also think that there's no afterlife at all. As far as the individual is concerned, awareness that life will end is something when we are well, when we're young especially, sometimes in the future, not of immediate concern unless it's somebody in the family or friends are very ill. Perhaps a reminder that death is certain, personal. When for me? How will it be for me? At the same time, it gives an opportunity to evaluate one's own life and find the meaning and purpose of life. With every progressive illness, there are hopes. It's amazing to see how advanced ill they are. They still got hopes, either of cure or control, or if it's the end, it'll be peaceful and quick. But the realities are that what we see is people who have got progressive illness. They can be stable for many months or years, or be unstable, or deteriorate rapidly. And there's always this push and pull, as I mentioned earlier, with clinical interventions, sometimes rather inappropriate and costly. And also talking about dying and death is difficult with patient and family and doctors. And as you know, in some of our cultures, even talking about being ill is not acceptable. But it's true that people do prepare for death in their own way. How will life end? Death has many doors, but life but one. So it can be sudden, as you have a heart attack, road accident, and so on. It can be protracted. It's expected or accepted, suffering or peaceful, wanting and waiting. And we have patients who are progressing. Why is it taking so long to die? As life ebbs, we in the hospice movement have gone to homes of people to help them. Here are some pictures. The top three show of staff as well, a doctor with a patient. So even though there's a mask on, you can see she's depressed. And here is a doctor and a nurse with a patient, the family, having a family conference. And here's another doctor sitting on the floor with a very ill child and a mother. And the bottom two pictures show some of the patients we had. The patient may or may not be aware that the end is near, and may or may not be conscious at that point in time. And their desires will be not to suffer, not prolonged end. Sometimes time to go, especially if they finish the agenda. And they want to be cared to the end, not to be a burden, looking for reconciliation, forgiveness. I think in every family there will be skeletons in the cupboard. The family future is safeguarded. Often, very often, they want to die at home. In fact, I would say most of our patients will die at home. And of course, they will want to be remembered. As I said earlier, there's an opportunity to prepare for death, gets one's affairs in order, fulfill some wishes, plan where to die in the funeral, time to say goodbye, allows for patient and family to come to terms, give and receive love, and perhaps life's purpose be transformed. Oh, sorry, why my first slide went to there. Some family concerns are this. How will he die? When will he die? Pain relief. Cannot talk, case and death. For instance, there are some families who will object to the use of opioids, because they feel that the person cannot talk. There's a strong desire in many families that they are able to communicate right till the last breath. We starve to death, die of thirst. Will hydration prolong the end? letting go or not. It's an ambivalence. And the place of death, kind of funeral, and over assets. Well, fortunately, we have families as carers in our country, available in our cultures. And sometimes it's difficult to know who is the deciding factor in the family. How is it individual decision making or the family has a say? And I think mostly in our culture, it is never individual decision making. The family is involved as well. And we see families which are functional or dysfunctional because all this affects how the person gets care. And sometimes they don't want to discuss the diagnosis at all or tell the patient what the issues about fear or opioids. They don't want to use the opioids at all. And then who will take care? When there's a number of siblings involved, who will take care and where? And who will get rest when there will be carers? Who will care for the dependents? And issues of religion. Sometimes people who have converted, one person in the family has converted. It could be the wife or the husband, or a child could have been converted. And that comes, it can lead to problems in the family. And of course, in this country, care at home, there's no professional medical or social carers at home. Just to show some examples here, the picture on top is of a lady in a care home, and you can see in a little room how crowded it is. Some of our patients are in care homes, but not less than 5%, I would say. And bottom two indicate 2 points I want to make. One is about what the person who dies is concerned about, and that is one is the picture of the young man sitting beside the lady on the floor who's got advanced cancer. Is her concern was not that she was going to die or how she was going to die. Her concern was this young man who was an OKU and an epileptic. Will his siblings look after him? And the other one is a widow, 36-year-old lady, advanced CA stomach, and her concern was who is going to look after the children. Okay. Well, it's very difficult to say when the final days are, you look at the literature. Okay, I'll have to rush through very fast. Basically, I'll just the 3 or 4 slides of that. Basically, there's a gradual withdrawal of the person from surroundings and gradually of themselves in terms of taking food and so on. I'll go through that very quickly. There are some guidelines for doctors and nurses. Every patient's problems are unique and they're not only medical. And you must be a good communicator, you must be competent, but also aware that may not have all the answers. Be compassionate and empathy. They must be aware of the patient, whether he's competent and what the wishes are, what the family wishes are, and whether they differ or not. And be very guarded about prognosis, but be honest about it, very guarded. Don't say things like, which we are told that patients, this is what the patient tells us or the family tells us. The doctor said, your father's got 1 week to live. Well, your father's got 1 month to live. So I think your prognosis must be honest but guarded. Question of days, question of weeks, question of months. And help family make informed decisions. And it's sometimes very complicated to arrive at decisions. And help the family cope, see how they're coping. The family will need more support. And following the death, bereavement support. Of course, these are some of the ethical issues at the end of life. Okay, I think most of you, some of you are doctors, you will be aware of it. I'll go over that. Management, these are some of the principles. Basically, you want to care and compel till the end. And good symptom control, review the drugs, avoid unnecessary interventions, and have good nursing care, and all the while inform and explain to them and support the family. This is an example where pain is concerned. You provide medications till the end, but review the drugs, the route, and the mode of giving the drug. Finally, that is when death occurs, then of course all our cultures, apart from the fact that grief is physiological and occurs in everybody, our cultures have got various ways in which to mourn. And I think most of us will be aware how the different races in this country do their mourning. It is a way of saying farewell to the person who has died, and also to support the ones who have lost a member. This comes from the British Medical Journal, and these are things which ideally what is thought to be a good death. I think the challenge for clinicians is to recognize that whole person care from diagnosis is a good medical practice. And this Harvey Cushing talks about it very broadly. Physician is obligated to consider more than the deceased organ, more even than the whole man. He must view the man in his world. And I'm afraid in our training, in the way we as doctors look after patients, I don't think many of us observe that. They're looking of a man's illness, not only of his own illness, but of him as a part of humanity. Yeah? But there are global concerns now about increasing care needs, long-term care, and so on, all about excess care, quality care, sites of care, who will pay, and so on and so forth, and the inevitable ethical dilemmas which are arising more and more now. And I'll end with this quotation by Callahan. You could read it. So, to relieve suffering is a core, it's the foundation for the practice of medicine and all our social welfare programs. Thank you.
Thank you, Dr. Sri. That was very interesting, and I'm sure some of you have got some queries, but we still, go ahead. We still have to move on. We have our next speaker who will be giving the legal aspects on the end-of-life issues, and this is Datin Renuka Devi, who is a lawyer by profession, but not only that, she also has a degree in nutrition and dietetics. She's still practicing as an advocate, and she has her own law practice, and she has presented several papers at medical conferences in relation to law, and has run workshops for medical professionals locally and internationally. She does public talks relating to legal issues in various fields, and she also helps out with the Malaysian Healthy Aging Society, where she held the post of honorary secretary before. And she is now currently helping in organizing the 4th World Congress of Healthy Aging in Belfast, which was supposed to be in 2021, but the conference had been postponed. So, without much ado, let us welcome Datin Renuka Devi, who will speak on the legal aspects of end-of-life issues.
Again, technical problem. So sorry because I know I've got very short time. Because the next topic is actually a very interesting topic. It's going to be held in the ballroom. It's by Professor Adiba Kamal-Zaman on COVID and the elderly. Very important, right? So I thought I'll do it fast, but I'm only going to talk on the legal aspect. Like doctor talked on suicide prevention. Dato Sri talked on all the end of life, very soft and very interesting. But I'm going to bring you all to the realities of life, where I'm going to talk about the legal aspects. Okay? That doesn't look like my slide. Okay, now mind. Some parts are missing, I think. Can someone fix this? Huh? What happened to this? Okay, now I think down. All right. Okay. Right? I think my voice is loud enough, right? Can you all hear me? Oh, I see. Okay. Okay, I will talk on, I want to talk to you all about the Federal Constitution of Malaysia, what are our rights. And in Article 5(1), it says, the liberty of a person, the liberty of the person, no person shall be deprived of life or personal liberty save in accordance with the law. So when we are talking about end of life, I prepared my talks on basic talk on palliative care, because that's what I thought, end of life, and a bit on suicide. So you see, otherwise we all is something inevitable. It is a natural phenomena. As you age, nobody can live for the rest of our life. Our science has not discovered anything yet. Maybe the future scientists might make us live forever, but till that comes, we all in the end is inevitable. But in consideration of end of life, consideration in decision-making process around terminal illness and quality of life, we have to consider legally. So what is end of life? According to WHO, in the palliative care, the way it's defined, it is actually to improve the quality of life and relief of suffering, and a treatment of pain from serious or potential fatal illness. That is what WHO is considering end of life. Okay, but the current situation in Malaysia, I prepared quite a long speech, but I think constraint of time, I'll just make it brief, if you all are okay with it. The current situation in Malaysia, at present there is no authority or standards that officially regulate end-of-life care in Malaysia. To date, there are no local jurisdiction decisions available, as issues pertaining to end-of-life care are treated as a medical decision. So what I'm trying to tell you all here is, however much, even you have written in a will, or you have some advance directives, which is not practiced in Malaysia, because if it's in a will, it only speaks after death. So even if you talk about living will, that's practiced in Western countries, we don't have it in Malaysia. And even if you put, you can have a power of attorney that gives somebody the right to make decisions, it supersedes a doctor's decision. So end of the day, it's in the hands of a doctor what he wants to do. Even the court will not interfere. However, in section 300 of the Penal Code, the definition of murder is with intention. I wanted to talk about mens rea, actus rea, and all these are legal terms. But I suppose you all know, right? Murder is with intention. When there's no intention, it's culpable homicide. So an act of death is caused intentionally for murder, or B, intentionally cause body injury which is likely to be the cause of the death. C, person committing the act knows that it must in all probability will be the cause of the death. D, commit such an act that is imminently dangerous that it must probably cause death. So whatever he does, he knows his action is going to cause the death of the victim. So that is murder. And for punishment is by death or imprisonment. Imprisonment comes under section 300 of the Penal Code. However, we have another section, section 299 of the Penal Code, which is called culpable homicide, where it is not intentional, but the act causes the death of the person. So whoever caused death by doing an act with the intention of causing death or with the intention of causing such bodily injury as it is likely to cause death, or with the knowledge he is likely by such an act cause death, commits the offence of culpable homicide. And of course, in law, we always have exceptions. We have an exception to this, for exception to 300, which is exception 5, culpable homicide is not murder. When a person whose death is caused, being above the age of 18 years, suffers death or takes the risk of his own, takes the risk of death with his own consent. What is that? Suicide, right? So, with that in mind, let's look at euthanasia, which is non-voluntary or involuntary, which is always in a palliative care. In sometimes it is in a subtle way practiced in Malaysia with the consent of the victim, which falls under the exception of section 5 of 300. This is sometimes, where I've also been told that you withdraw treatment or you slow down the process of treatment, which helps accelerate the death of the person involved. Is that fair in law? It is not. It is considered murder. But the decision is still in the hands of the medical profession who is practicing it. So the courts will not intervene. So consent, which is mutual understanding between the person carrying out the act and the consenting party. It falls under section 299, which I told you is only applicable if the patient consenting is of sound mind. Or what if he is not of sound mind? Comatose stage, is under life support. What happens then? The family, immediate family, can decide for the patient. However, with the consent, with the advice from the doctor treating the patient. If the doctor says no, even in a small, he has got a slight chance, they cannot do it. The family's decision will be overthrown. I've seen this in many cases, in cases that I had to handle sometimes. Suicide victims, sometimes it's so bad they are not able to die, but their suffering is prolonged. The family will intervene, ask the lawyers to intervene and say, this is our wish. We don't want him to suffer. We can only appeal to the doctor. But if the doctor says no, there is a chance he can be saved, there's nothing we can do. But of course, in Western countries, there are cases you would have heard that they go to the court. Here in Malaysia, no such decisions has happened or taken place. So under the common law, a person is under a legal duty to act if he stands in certain stature with the other party, and failure to properly exercise such duty would render such person liable for civil negligence. Example, a child left alone in a locked car. You all would have heard it, right? There are cases that happen. That falls under Child's Act 2001. Withholding or withdrawal of life-sustaining treatment. Euthanasia, right? That falls under Code of Medical Ethics, issued by the Malaysian Medical Association, that is the CME. So all this doesn't come under the jurisdiction of the court. So what about individual autonomy? Is an ethical right which is imbibed in and protected by both civil law and criminal law. Like I told you, in our constitution, the right of a person's life. Consent must be obtained when administering treatment. A refusal must also be complied with. If that's the case, there are a lot of terminal ill patients who would like to end their life, It's dying with dignity. But most of the time, doctors, medical profession or medical principles overrule all their decision. So it's end of the day. It's still in Malaysia. It's still in the hands of the doctor treating the patient. In Malaysia, there is no legislation in Malaysia. Active euthanasia is recognized as a situation in which exception would operate, like act done in good faith or for the benefit of the person without consent. Under Section 92, there is nothing is an offence by reason of any harm which it may cause to a person for whose benefit it is done in good faith, even without the person's consent. There are some situations where a person goes under life support and there's no life, and once you pull out the machine, there is no life after that. They pass on. But even in a decision like that, sometimes I've seen families cannot let go of the patient. So they put them on life support. And when the insurance don't cover, then it becomes a difficult situation. And then, they have gone to the doctors to decide, where the doctors have pulled up the support. If the circumstances are such that it is impossible for that person to slightly consent, or even if consent is incapable of giving consent, even if the person is incapable of giving the consent and has no guardian or other person in law in charge of him from whom it is possible to obtain consent in a time for the thing to be done with benefit. So in that circumstances, sometimes doctors take the decision. And of course, these are not recorded because it's illegal, and it cannot be, they cannot come out to say that they have done some illegal act. It's done very subtly, but I know for a fact that it is happening on, on grounds of not wanting to prolong the suffering. So with that, I know time is constrained. I've taken more time. I end my talk now. Thank you.